Wait a second. Is it visible?
No, please share your screen. Click on share and then the screen and then share.
Yeah, I know, maybe some net connectivity issues. It's
Okay,
not coming.
You can just say by like.
Okay, I'm just saying that let's not waste time. We have our chairperson as Professor Dr. Raghunath Mishra sir. He's the principal of College of Medicine, Shagat Datto Hospital, Government of West Bengal. He's an old member of association. He was past joint secretary, general secretary, vice president, and president of IPSM. We have with us a speaker, Dr. Professor Sujoy Ghosh. He's a professor, Department of Endocrinology, SSKM Hospital. He is the National Secretary, Endocrine Society of India, National Joint Secretary, Indian Thyroid Society, and National Joint Secretary, Research Society for the Study of Diabetes in India. We have a second speaker, our dear Dr. Bobby Pal. She's Associate Professor of Preventive and Social Medicine, All India Institute of Hygiene and Public Health, Government of India. She's the Managing Editor of Journal of Comprehensive Health. So, and I'm Dr. Shamima Yasmin, Assistant Professor, Community Medicine, Medical College, Kolkata. So, I hand over to our chairperson, Raghunath Mishra sir. Sir, please.
Thank you, Shamima. It is my great pleasure to chair the session on diabetes mellitus, and in which the speakers are Professor Dr. Sujoy Ghosh and Dr. Bobby Pal. So it is my proud privilege also. And here, the diabetes mellitus in the stage of epidemic transition. Now, we control almost all the almost the communicable disease and neonatal disease, nutritional disease, maternal death, but gradually increasing these non-communicable disease, particularly diabetes mellitus. And the disease has become increasing in rate throughout the world, and also most important in our country, India. And in transition phase, now it is clear that now it is not the disease of old age. Now it is gradually becoming a disease of younger age also. Type 2 diabetes now affecting the younger age. So here, in this particular disease, where all levels of prevention is essential to control this public health problem, our public health issue. And here, our Sujoy Ghosh, which is very familiar to us and everyone, who is a renowned physician, endocrinologist, clinician, awarded by so many awards, and he is a great author of so many books, and he is our proud of our state, but he is always our Sujoy, beloved Sujoy, always with his students, always with his research, always with his special clinics, and every day he is opening one new idea, and every day by day he is uprising by stairs. So this is our Sujoy. And another speaker, he is very keen to me, that is Bobby Pal. I could not say anything about Bobby. He is my sister. She is my sister. She is my daughter. She is with us so many years. So I hope the program will be very effective, and every participant will enjoy this program, and they will get oriented with this disease, and also they will oriented this public health challenge. So thank you, and so start this program by Sujoy and Bobby. Thank you all.
I would please request Dr. Sujoy Ghosh to start.
At the very outset, I would like to thank Raghunath sir for that very kind and warm welcome. And of course, a big thank you to your association for having given me and Dr. Pal an opportunity to share the platform to try and talk about something which is very, very close to my heart. You know, we already have a national program on non-communicable diseases in young. And one of the aspects that's probably neglected in that is something that we are going to discuss together. And I was listening to the speakers in the previous session, and people were talking about the various opportunities that one has in public health and community medicine. Unfortunately, I'm like a fish out of water. I have not been trained in public health, but I do realize that that's where probably the greatest opportunity lies in terms of making changes to the system. And so let me and Dr. Pal try and share with you some of our own experiences and what we intend to do. We will be trying to finish so that we catch up with your sessions and finish by 7. So I'm going to talk about diabetes in young, a public health challenge. And my first declaration and conflict of interest is that I am an employee of the government of West Bengal. Diabetes in young has a very, very weird definition, because depending on who you are quoting, some would say it's because if somebody is diagnosed with diabetes below the age of 25, others would say that it's below the age of 30. But I would probably go by the definition of 25 worldwide. Now, if you do that, you can see almost about 50% of the population in India is at age 21 or below. The reason why I'm saying this is when we talk about any disease and say, oh, okay, 5% of the population is affected or 1% of the population is affected, the ultimate numbers depend upon the denominator. So if 50% of Indians are below 21, and even if you have a disease which is not that common compared to maybe some of the other diseases, it ultimately means you're dealing with a huge disease burden. So when we talk about diabetes in young, when we were MBBS students, we kind of thought that it was type 1 diabetes, or what was previously called juvenile diabetes, is the only form of type 1, or maybe the most important diabetes in young. We now realize that type 2 diabetes, which is the common diabetes in adults, is gradually increasing in numbers. And of course, there are various other kinds of secondary diabetes that can happen in the young. So we are talking about a mixed bag of problems in young individuals with diabetes. So if you look at Dr. Mohan's data of patients attending the Mohan's clinic down south in Chennai, you can see gradually over a period of time in the last 30 years or so, number of children with diabetes is progressively increasing, telling us essentially that the problem is on the rise. And what's more important is that if you look at the 90s, it was predominantly type 1 diabetes. But as you can see, the numbers are increasing, but the gap between type 1 and type 2 is coming down, essentially telling us that type 2 diabetes is increasing rapidly by leaps and bounds in India. And if you compare the Indian population or the South Asian population with Chinese and the white population, you can clearly see that after attainment of puberty in South Asians, there seems to be a dramatic increase in the prevalence of an incidence of type 2 diabetes. So diabetes per se in young, in our ethnic population, is rapidly increasing. And I'm going to talk predominantly on type 1 diabetes, and I'll tell you why a little later. But if you look at various studies that have been published in the last 50 years or so, the exact number of people with type 1 diabetes, we really do not know. And it is suggested that the incidence of type 1 diabetes is increasing by about 3% per annum. Actually, tomorrow, the new IDF Atlas is going to get published, the next edition, to which I have some information of. And this is the last IDF Atlas. And what you can see is when you're talking about incidence or prevalence, India is number 1 in terms of type 1 diabetes. When we were students, we were taught type 1 diabetes happens in the Scandinavian nations, whether you're talking about Sweden, Finland, Denmark, or even the northern part of the United Kingdom. But because our denominator is so big, even a lower rate of disease actually contributes to higher numbers. So the IDF Atlas now states that India has probably 2 lakh individuals with type 1 diabetes below the age of 14 years. And I think that's a gross underestimation. So maybe 1 in 5 or maybe 1 in 6, this is the older data, that in India, every 1 in 5 or every 1 in 6 child with type 1 diabetes is an Indian. That's pretty scary. Now, if you look at the ICMR registry, which Dr. Pal is going to talk about a little later as well, you can see 2/3 of all diabetes in young, according to the ICMR Young Diabetes Registry, is still type 1 diabetes. Now, at our own center in Kolkata in IPGMER, we've looked at almost about 500 plus children with diabetes. These are the kids. And if you look at, again here, type 2 diabetes seems to be increasing leaps and bounds in children. And remember, our cutoff of young is 25 to 30 years. So had we cut it down to somewhere around 15 or 20, that proportion of type 2 would have gone out of the window. We would have had more type 1 diabetes. The other two, if you see in green, is fibrocalculous pancreatic diabetes. And the secondary one, that's 8%, is quite a big chunk. Now, this is because of certain biases. I run a clinic looking at fibrocalculous pancreatic diabetes as a referral center. So that's one of the reasons. And the other is because I look at secondary diabetes in another cohort study of ours, where we look at diabetes in thalassemia children. So those two are probably an overestimation because of the fact of referral biases to my clinic. And you can see that prevalence of type 1 in our studies lower than that reported in the type 2s elsewhere. And maybe the higher cutoffs that we've used accounts for more type 2 than type 1s. And like I said, we've got biases in the reporting as well. So when we are talking about type 1 versus type 2 for the basic physician or the clinician, there have been various studies which have tried to show that, in terms of the diagnosis, can you make out which is type 1 or which is type 2? I think that's something that I should not be talking about here, but it's important to remember that differentiation of diagnosis is important because the management, the outcome, and the complications are entirely different. So from our own data, we've been able to predict that if a child comes before the age of 16, it's probably more likely to be type 1. And if you check for pancreatic insulin production reserves, which we look at in terms of the C-peptide, it's negligible or undetectable, telling us that the pancreas is unable to produce insulin anymore, and these children do not have dyslipidemia. On the other hand, type 2s have some amount of insulin preserved and tend to have dyslipidemia. So in children with type 1, there's a rapid onset of the disease. They often present with ketoacidosis. If you're unable to diagnose and start insulin, that will essentially lead to death within days. Insulin is life-saving. You cannot stop insulin even for a day. And because there is absolutely no insulin in the body, the child is entirely dependent on insulin that's provided exogenously. Therefore, there is wide swings in blood glucose, multiple hypoglycemias, and these children need intensive treatment, constant monitoring of their blood glucose. And it's unfortunate, but the reality is, as MBBS students, even as MD students, we were not that very well trained to handle children with type 1 diabetes. And what we find is anytime a doctor sees a child with diabetes, he feels scared. And some of my friends have said, the two things that people are worried about is one is trying to use insulin in children, and the other is using antiarrhythmics. At least now we have amiodarone, which has solved most of the problems with the antiarrhythmics. But the healthcare professionals, they are actually scared to manage children with diabetes. And therefore, they tend to send either patients to the referral centers. And we need better education, better training, so that, we can build capacity to manage type 1 children. These children, along with their families, need intensive education with regards to how to manage problems. They have severe psychosocial issues, and which keep on changing with time. And they tend to have complications, which are perhaps even much more commoner than in type 2 diabetes, and they tend to develop it early because one of the determinants of complication in diabetes is duration of disease. So if a child develops type 1 diabetes at age 5, you can well imagine that how quickly he would or she would develop complications. The challenges of type 1 diabetes in India is, first of all, is complete lack of awareness. A lot of doctors, let alone other healthcare professionals, are not aware of the presenting signs and symptoms of type 1 diabetes. There are several wrong beliefs about type 1 diabetes. You will find people on YouTube and the internet as well as social media talking about the gurus and babajis curing type 1 diabetes, all utter nonsense. There's absolutely limited healthcare access to these children. The healthcare professionals are not at all trained. There's lack of infrastructure and human resources. And I remember still about 10, 15 years ago, there was an article, a cover story of Lancet, which said the main cause of death in type 1 diabetes is drugs. And then there was a pause to say the lack of it. We don't have insulin supplies reaching to everyone. And of course, glucometers and strip is more of a luxury for most of the population in India. And if you look at the costs, it's enormous. In India, in Kolkata, for example, a type 1 child's family will have to spend somewhere around close to 4,000 rupees every month for basic minimum treatment of type 1 diabetes. And God forbid, if there is complications, need for admissions, the cost will go up even much higher. So therefore, to a lot of families, it's better that the child perishes rather than trying to spend for the child. That's the harsh reality. And in terms of healthcare policies, we don't have any medical support of insulins, syringes, glucometer strips for children with diabetes. Emergency care or support for children, particularly in remote area with diabetes, there's none. There's no facilities for diabetes education. We still in the government of West Bengal or anywhere, perhaps in the government sector, there is no post of a diabetes educator. Posts of even nutritionists most of them are lying vacant or, no new recruitments. There's no program to support management of children with diabetes. And you're talking about other issues like employment, like insurance, like jobs. There's a huge lot of discrimination going on and no social security. So if you look at, evolution of Indian national programs, in 2008, you first had the first NPCDCS with no mention of type 1 diabetes. And in terms of the national health programs and type 1 diabetes, it's absolutely disjointed. Everybody's trying to do their bit in piecemeal. And if you look at the latest national guideline, and if you do a control F and try to figure out where does type 1 diabetes figure there or diabetes in young figure there, we're talking about NCDs, diabetes in young, and type 1 diabetes does not even figure in our national program. No initiatives have been taken still today for management of type 1 diabetes. So we are badly in need of a program for type 1 diabetes, which will at least help address basic medication, basic monitoring, basic counseling, and provide for emergency care in children with diabetes. So we have, like the previous speakers were talking about, tried to take a few small steps towards that. It's one thing to know that there's a science and practice gap, but we need to have some kind of an implementation of what we already know to try and improve things. And what we essentially need to know or create is a model for management of diabetes in young, with special emphasis in type 1 diabetes, because managing the other forms of diabetes in young probably is not going to be that big an issue, but trying to create a model for delivery of type 1 diabetes is going to be a huge, huge, huge challenge. So we are in the process of implementation of a project on type 1 diabetes. And our objectives would be to provide comprehensive health care, providing education and counseling, training of the human resources, capacity building, and of course, building registries of patients. And as an offshoot also, we could probably think of other research areas, including looking at basic science in type 1 diabetes. So we've already talked about the various aspects of the project. And we are going to start a pilot in 5 districts, wherein we are going to try and target about 600 children with type 1 diabetes. For logistic reasons, we have thought of starting these pilots in the districts in and around Kolkata. And we would be essentially targeting the district general hospitals of the 5 districts in and around Kolkata, where we would be converting or upgrading the currently existing NCD clinics, where once a week, preferably on the same day of the week, we are going to train up the doctors, the nurses there, and the data entry operator there to deliver type 1 diabetes care. So we've written up a document, which is kind of a supplementary document to the currently existing national program. And we will be trying to provide them with insulin, free glucometers, and the strips. And we would be actually delivering basic health care for management of type 1 diabetes. We will be providing counseling to these children, education to these children, teaching them how to actually monitor blood glucose, how to adjust insulin doses, how to avoid and manage hypoglycemia, what to do on days that they are unwell. And of course, we would be building a registry as well. And the first thing to do would be training up of the human resources who would be working in these places. And, to start with, we would probably be sending back children who are coming to the main hospitals in Kolkata to the places closer to their homes. And more importantly, we would be creating mass awareness amongst ASHA workers, ANMs, and Anganwadi workers, so that they would be referring on children that they know to be suffering from diabetes to these particular centers. So the roadmap, a checklist of required infrastructure is being prepared. There'll be initial inspection of the site, the NCD clinic in these district general hospitals. Named staff at these clinics will be identified after consulting local authorities. Depending on what we find is lacking in terms of infrastructure, that would be put in place. And the resident medical officers, though I understand RMO post is being, done away with, one of the junior faculty members would be asked to be the mentor in that particular center and would help. And there'll be a lot of hand-holding in place, which would actually help them to make sure that the staff there get trained and that they're able to run the clinics on their own. So the government of West Bengal has been kind enough to actually support this project. We had applied to the central government as a project in partnership, and this is going to be a project in partnership, a project in innovation that the central government and the state government is both supporting it. And this is some of the bits that we've already done. We've created a software with an app and provided a tab to all of these 5 centers. This is what a typical diary would look like in terms of the data that we would be collating. And hoping that if it really works in these 5 pilot centers, we would be able to convince the government to scale it up at a state level. And let us hope and pray that we are successful. Like I said, all that we can do is try and see whether it works. If it does, then maybe we could persuade the central government to make it part of the national policy. So this is going to be a form of implementation research where we are not going to do anything rocket science, but just trying to deliver the basic stuff that we are being taught but unable to deliver at this present point of time. I shall stop there and request the organizers to continue with the session with Dr. Pal. Thank you very much.
Thank you so much, sir, for enriching us. The project looks really good, sir. All the best for your upcoming project.
Thank you very much.
Thank you so much, sir, for enriching us. So next, I would request Dr. Bobby Pal to continue with the program.
Thank you, Dr. Shamima Yasmin. And thank you, Raghunath sir, our dear sir, who has given a very warm welcome to this session. Though this is the fag end of the evening, I must say. But yes, this is a program that we have been developing with Professor Sujoy Ghosh since last 2-3 years, I must say. And it is on the verge of implementation. And with this, while we were discussing implementing the project, we thought that the conversation should start in the public health forum regarding the importance of care of young diabetics as in the public health way to incorporate these children's care within the existing public health framework. But yes, there are certain hurdles, and there are, of course, when you have a hurdle, you have to look for a way forward. So with this, I'll start my presentation. I'll be sharing my screen. Is my screen visible?
Yes,
Yes, it is.
visible.
Okay, I'll be quick enough. Yes, I reiterate Professor Shuja Ghosh's opening lines that there was a time that the term juvenile diabetes was synonymous with type 1 diabetes. And I remember when I was doing my MBBS, I once visited my maternal uncle, one of my maternal uncles, and my relatives told that, oh, just go and sympathize with him. He's a case of juvenile diabetes. We are going to lose him. Rather, he's a lost case. Even in our MBBS times, we were never taught in such a, or we were never mentored in such a manner that we give an importance to type 1 diabetes or diabetes amongst the young. Whereas, as Sir has rightly pointed out, type 1 and type 2 gap is bridging. And probably in this COVID pandemic, with the this obesity pandemic is also striking amongst the adolescents, maybe in a year or two, there will be a time that the type 2 diabetes will overshoot type 1 diabetes. And so this diabetes amongst the young will come into the public health framework with a big bang, just as COVID pandemic came with a big bang. Are we prepared? So that's the question. So a recent analysis suggests that given the current population projections and observed trends globally, the number of youth with type 1 diabetes mellitus will nearly triple, and type 2 diabetes mellitus prevalence will probably quadruple by 2050. You know, as Sir had rightly pointed out, that the care for young diabetes is actually different. And as the numbers are increasing day by day, that is, it is 3 to 5% per year as per the International Diabetes Federation's
Dr. Pal,
database.
Sorry to interrupt. Could you actually make it full screen and make sure that your slides are moving? Your slides aren't moving yet.
Is it? Here it is moving.
Right.
No, sir, no, ma'am, not in the screen.
Slides are not moving.
I think I'm
Stop
having
sharing
some
and
net issues.
reshare your desktop, and then again project your slides and then share it full screen.
Okay. Is it visible, sir?
Visible, but now make it full screen.
Yeah.
Correct.
Is it visible now?
Yes.
So with this, as Sir has built up the conversation around the problems that these type 1 diabetes children are facing, and with the emerging global pandemic of obesity amongst the adolescents, and with the future projections of type 2 diabetes looming large amongst the youth, the few emergent questions in the public health perspective are, first, we have to estimate to what extent the burden of youth onset diabetes is increasing in India. Without this estimate, we cannot think of even including this issue in a public health program, as we need a denominator by which we can progress with our plans. Probably that was the one reason we focused our implementation research project amongst the 5 districts. where the denominator was actually present and the data was with SIRS Tertiary Care Center.
Can everyone mute, please? Carry.
The next question is, I think organizers please mute the others.
I think Arup Chakraborty needs to get muted.
Claunet, please mute. Nishita, please mute the. There are some persons who have been unmuted. Okay.
The next question is, have we ever tried to hear the voices of the young diabetics pertaining to their health needs for a better quality of life? I did quite a lot of searching, database searching regarding publications, Indian publications regarding these questions. But sorry to say, they are, what do I say? They are rare, not few, they are rare. Is our health system prepared to tackle the specific needs of the young diabetics? As Sir has rightly pointed out, that even in our MBBS days, we were never given this opportunity to learn regarding, because this type 1 diabetes, it was thought to be a public health problem in the Scandinavian countries. And whenever, even if I have a patient of type 1 diabetes, the stark reality is in a metro city like Kolkata, there are very, very few physicians who are actually prepared to receive those patients. Majority of them say, no, I don't treat young diabetics. Okay. The fourth question is there any need for initializing opportunistic screening programs for detecting young diabetics? Because you see, in the Western world, where in the US, where actually the incidence is quite high, it is around 193 per lakh population, as Sir had shown before. There, the American Diabetic Association, they have their own recommendations and they have their screening programs. But this is a question of debate, whether to start or not. But since we don't have denominator, maybe with this CBAC form, if we have this opportunistic screening available at the NCD clinics, maybe we can detect the young diabetics in our public health infrastructure. Now, the question is, do we have culturally specific and acceptable model chronic care strategies for them? Actually, that is what we are trying to develop. And has the time come for the public health professionals to intervene by providing programmatic support to the young diabetics? The conversation should start. This is, I think, the right time. The burden is increasing. But sorry to say, for the last 1 year, I was attending all the national programs, but I did not hear a single word. Even there were diabetes sessions as well from our own central government forum, but there was not a single word regarding this young diabetes management. So I'll be brief in giving a snapshot view of the available public health framework in the Indian context and the way forward, maybe the avenues that we can explore to bring this looming large burden into our own public health framework and manage it efficiently. The first is, as I told you, the data availability is very limited. ICMR established this YDR registry, that is the Registry of People with Diabetes with Young Age at Onset in 2006, which is actually the only available data. And regarding their publications, which I found, and I also talked to Sir, and he also said that probably that is the last publication in 2016, which showed that the data is available for 5,556 people, 56 children. The registry started with 5 regional collaborating centers and 3 more were added in the year 2009. So you see, the denominator is not yet clear to us. That is how much, how many. And there are specific challenges of the YDR data. That is, being a hospital-based registry, the YDR estimates may not reflect the actual population burden of youth onset diabetes in India. There are countries where there are population-based registries. But here, I think probably the conversations should start that the shifting of this YDR hospital-based registry to population-based registry. Otherwise, we will not get the true picture anyhow. The second challenge is the ascertainment rate of the YDR has not been identified. Probably tools like capture-recapture technique can be used in future to fix the ascertainment rate. And here, actually, they have used the clinical criteria to classify diabetes. This is because the reporting centers, many of the reporting centers did not have the facility to test the autoantibodies. So actually, there is a chance of misclassification due to overlap of the clinical. This is one reason there is a chance of misclassification. Another reason of chance of misclassification may be due to the overlap of clinical phenotypes at the onset. And also, usually the tests that are used to detect the comorbidities and complications are not available in our public health framework. We all know. And they are usually paid out of pocket by the families who are already stressed while managing type 1 diabetes. So there is a chance of missing the actual picture of their natural history of disease of the Indian population. So that is also very important. While we are thinking of framing a chronic care model, we don't have actually the picture very clear in front of us. So what should be the way forward in this scenario? Probably to create a national registry of diabetes in the young involving multiple centers across the country. I think this is doable in our present scenario where we are thinking of including NFALD in our program. That was also previously not thought of as a very important problem, but now people have realized and they are bringing NFLD in our programmatic picture. So if we try to find out actually the burden by building up a population registry, including a variety of healthcare systems and diabetes care providers, or maybe the electronic health record system. That was the plan of Government of India way back in 2014, and it is also recorded in our national health policy as well. That is in 2017 to introduce this EHR, but it is yet to be done. But once it is done, just like Aadhaar card, the enumeration will be very easy, I think. The initiation of population-based registry that I was talking about, that is the shift from hospital-based registry to population-based registry. The initiation of screening programs at school and health facilities. That is that actually we have to see the feasibility here. That is the costs involved versus the yield. Actually, in certain countries like Japan and Taiwan, there are screening programs for diabetes by urine dipsticks method. So this is one method, that is urine dipsticks method, that can be introduced easily in our school health program, that the cost is about ₹10 per person, and it will come down when it is implemented in a large population, and thereby we can detect a number of people, even the number of urinary abnormalities as well, and including glycosuria. So this is one opportunity. Or maybe we can use our own IDRS, that is the Indian Diabetes Risk Score, at the college university level to identify at-risk population. Just as in our university own WBUHS, we have the notification of thalassemia whenever a person enters this university. So maybe this is another opportunity, but we have to explore. But essentially, to start any program for young diabetics, first and foremost requirement is the denominator. And for that, we need an effective registry that will help children living with diabetes claim their position under the sun, effective for effective budgetary allocation as well. As I was talking about the need for early screening, since Indians, this is well established, they are a high ethnic risk group. So screening programs can be initiated for early detection of type 2D. But in our Indian context, I did not find any such recommendation. But American Diabetic Association, ADA, they suggest that it should be done every 3 years or more, frequently if BMI of a child is increasing. And if you see it from the public health framework, there is a scope of introducing this diabetes screening in school health program or opportunistic screening at hospitals and health centers, that is in the pediatric OPDs for the high-risk children. But again, I told you, this feasibility studies are required to explore the economic implications versus the yield. And if you see their guidelines, that is ADA guidelines for opportunistic screening, it is not unrealistic. This can be adopted. But of course, we have to explore, and the experts have to be roped in to see the feasibility. That is the children more than 10 years in age who are overweight and have any one of the following risk factors. That is either family history of type 2 DM in first or second degree relative, the signs of insulin resistance or conditions associated with insulin resistance, maternal history of diabetes or GDM during the child's gestation. So the proposed two-pronged strategies for young diabetes prevention and care. Number one is integrate care of young diabetics within the existing health system. And number two is create, sustain, and expand health promoting environments to reduce the modifiable risk factors. Now we have an existing framework, that is a robust NPCDCS program.
Nishita, please mute everyone.
So we have an existing framework, that is the robust NPCDCS program. So it is not an impossible task to integrate the care for young diabetics within this existing framework, starting at the district level hospitals, because we are well aware from Dr. Ghosh's speech that they are very prone to complications. And this will help in optimization of the scarce resources and sharing the same administrative and financial structure for district level NCD cells will ensure the program feasibility and sustainability. Of course, we require a trained and motivated multidisciplinary team of specialists trained in pediatric diabetes management. And this is also not an impossible task. Once you have a module prepared, once you start rolling out the trainings, we will have trained teams who can be sensitive to the challenges of children and adolescents with type 1 diabetes and their families, and their families who are also equally stressed out, so that they can be counseled. Also the creation of posts like diabetes educators and the nutrition counselors, nutritionists also in this team should be there to provide care to this population. So capacity building is not a big task. We have seen previously, many of the programs have been rolled out previously also by training our own healthcare providers, and they are effectively being implemented as well. But we have to prepare a primary healthcare package, including the management protocols and the referral criteria for dealing with all types of diabetes amongst the young. And we have to ensure equitable access to affordable essential medicines, including insulin and the technologies. That is, this is very important for their survival, and for type 2, this is very important for their metabolic control. And the training of the grassroots level workers for providing support services and raise awareness amongst the general mass regarding the symptoms and signs of diabetes amongst the children and adolescents. Of course, there should be strategies to deal with the psychosocial issues, that is the presence of mental health professionals or counselors in pediatric, this multidisciplinary team I was talking about, where they can do the screening for the psychosocial problems that these children as well as the adolescents face. Actually, these children and adolescents, especially the adolescents, they are in the transition from childhood to adulthood. And they are sometimes rebellious. They are very jittery in sticking to that stringent type 1 regime that one has to follow for their metabolic control. And they cannot go about their own way. And neither they are in a position, they are in a mindset to listen to their parents. So this adolescent period is the time when they tend to slip out of their diabetes control and they land up with complications. So this is very important to deal with these adolescents where they are facing the transition from childhood to adulthood. And many of times the young diabetes patients, they are actually being treated by, what do I say, adult diabetologists. And they really are not in an understanding position to how, what stressful situation these children are going through. Another important point is at the onset of puberty, all adolescent girls should receive education about the risks of malformations associated with poor metabolic control. This should be stressed upon. Otherwise, you know what will be the problem? The congenital malformations may increase, and they should use the effective contraception to prevent the unplanned pregnancy. So here also, there is one point that is the counseling is required for these adolescent girls as well. So before framing the strategies for integrating this young diabetes care in our own public health framework, the first and foremost thing in my perspective is we need to hear the voices of people living with this youth onset DM and their caregivers. And its more in-depth understanding is needed to better ascertain the specific intervention targets. And the second way forward is we have to develop targeted behavioral intervention programs. Otherwise, you have your own recommendations, but they are children, they are adolescents, or they are young adults, and they are not in a listening mood to whatever you say, neither they are in a listening mood to understand the magnitude of the problems that they may face in future. So targeted behavioral intervention programs for young children with T1 DM and their caregivers are needed to reduce the risk for long-term complications. Till date, there are three very renowned trials regarding these intervention programs. One is the RISE, other is the Today, and another is the SURGE. But in Indian context, it is yet to be developed. So this is one for the care. The other prong strategy, the other prong is the creation, sustenance, and expansion of the health promoting environments to reduce the modifiable risk factors. So actually, we have to create a culturally and environmentally appropriate strategy to promote the intake of healthy food. Our own government is working towards it, and we have many interventions planned and implemented for promoting this intake of healthy food. That's true. The fiscal measures, but should be raised to raise on the sugar sweetened beverages and unhealthy food items. And this is a wish list, of course. That is, the price of the healthier food should be reduced. The regulation of the marketing of food and non-alcoholic beverages to children should be also seen to. The awareness generation on nutritional labeling, that is also coming. This FOPL, that is the front of package labeling. I think this will go a long way in creating a healthy food environment amongst the children and young adolescents. And of course, the promotion of breastfeeding, that is ongoing. And concept of the health promoting schools, which was an idea of the UNESCO and WHO. It has been adopted to some extent by our government of India. And just like we have implemented Swachh Bharat, we can also implement this health promoting schools and start developing each and every school in this line such that the schools become congenial to provide care in accordance with the child's individualized diabetes medical management. Actually, whenever we have seen as a public health person, actually I have seen, the headmasters, when they listen that the student is suffering from type 1, he says that, okay, you stay back home, you don't need to come. I don't want any complications out in my school, I can't handle. So this is actually the scenario that is prevalent. We have to change this. Introduction of nutrition and physical education in school curriculum and compulsory inclusion of the marks to the total grade. This is another wish list. Create supportive built and social environment for physical activity. We are talking about physical activity. Do we have enough space? Do we have enough time? Do we give them the children and the adolescents enough time to do physical activity? This is another question. And of course, the positive inclination of the media is required to stress upon the importance of lifestyle measures and modification measures amongst young children. This is somewhat progressing, of course, with our, what do I say, the celebrities coming in to advertise for this lifestyle modification measures. The last one is the research scope. We understand that there are many arenas where we can barge in for research. But again, the question is, do we have dedicated grants, funds, or are there any latest, have you seen any proposals which are calling, which are like calls which are calling for proposals in this area? Well, I haven't seen. But there are many, what I have identified while working with Dr. Ghosh for the last few years, there are many areas where we can do research and we can bring up evidence base, whereby we can implement from the chronic care models for these children. That is, first we have to look into the risk factors for all types of diabetes in children. We have to have intervention research to expand the evidence base for promotion of physical activity amongst them. We have to just what we are planning to do, the implementation research in a small scale. If it is successful, as Sir was telling, then we can have a brainstorming with the other centers who are looking into young diabetes care, and then we can better understand the scope of health system for integrating young diabetes care in NPCTCS and other relevant programs. Of course, the feasibility studies are required for introduction of diabetes screening program among school students and exploring the affordable options to improve access to insulin. There are many research options, but these I found are very relevant before starting even the baseline activities for including the young diabetes care in public health program. We have to find out optimal approaches to management of comorbidities and complications in youth onset type 2 diabetes, including lipids, because they are very prone to complications, this youth onset type 2 diabetes, as you all know. And we have to understand the impact of stress on the development, presentation, and management of the youth onset type 2. And the interventions, we have to find out what interventions will really work to increase compliance with lifestyle interventions and medications in adolescents with type 2 DM. So to summarize, actually we need a concerted multi-pronged effort involving general public, pediatricians, general physicians, teachers and schools, media, government, public health professionals, and professional medical bodies to create awareness regarding this looming large problem and generate a momentum towards the goal of prevention and care of diabetes in the young population of India. These are my references, and a sincere thanks to IPSMCon WE 2021 team for giving us opportunity to speak in this forum. With due regards to Arjikor Medical College team, and long live IPSM. Thank you.
Thank you, Dr. Poppypal. It was really enriching. Two things that really touch me is the two words. One is that we need a primary healthcare package. We really need that. And secondly is the adolescent problem associated with these diabetic children. Just to share one experience, yesterday we had gone to a rural field practice area and we found there that children of age 13, 14, they were alcoholic. And we're so surprised to see that. So if problem like type 1 diabetes is increasing both in absolute numbers, proportion and population, so we really need to work upon this, and implementation research is really required. The main issue you said is the fund. So hope we can, the expertise we share here will be taken care of. So next I would like our chairperson over to do our chairperson, Mishra sir. Sir, please provide the vote of thanks.
Sir, you are muted, sir. Please unmute yourself. Raghunath sir, you are muted. Kindly
Sir,
unmute yourself, sir. Yes, sir.
Thank you all, and particularly thanks to Professor Sujoy Ghosh and Dr. Bobby Pal for their very nice presentation in details. So clinical part is very nicely presented by Sujoy, and epidemiological public health part very nicely presented, and the new ideas are given by Bobby. So multi-pronged strategy is very essential for such type control of such type of newly emerging problems. So thank you again. Thank you both. Thank you all.
Thank you, everyone. We leave here next to over to next session.
Hello, thank you, Shaimadi. It was an extremely enriching session. So I am now coming to the next session. We are doing back-to-back sessions because of the time crunch, and thank you to all the speakers here because you made us back on track. So thank you for that also. Okay, so the next session is about COVID. This is because of COVID, we are not able to see each other. This is because of COVID, we have to do this kind of a conference, and this is because of COVID, we are doing this online